Professor Feng, for your kind introduction. So my task today is to talk about the highlights of the Chinese hypertension guideline. The full name of the guideline is Chinese Guidelines for the Prevention and the Treatment of Hypertension. This was drafted by the Task Force of Chinese Hypertension Guidelines, which was consisted of several societies of hypertension in China. Chinese Hypertension League led this drafting of this guideline. So we have 25 years history of drafting hypertension guidelines. The first edition was published in 1999, was a booklet, just a few pages on the introduction of the management of hypertension in our country. So this is the fifth edition of hypertension guideline, which was just released, published in the journal, Chinese Journal of Hypertension. Will be soon released in the full English version in another journal in China. This is multidisciplinary work because we have many societies collaborate with us, the Chinese Hypertension League, and also we have more than 100 members of the task force, and also I have a huge amount of references for the publication of this document. And this is mostly reflect the characteristic of Chinese hypertension patients, because also we remained at the threshold of the diagnosis of hypertension 140 over 90 mmHg, but for patients who untolerated, we encourage to lower the blood pressure as low as possible, which means 130 or 180 mmHg is our optimal target. We still remain the definition of the classification of stage 3 hypertension, because we also have 20 million of patients in this stage, which in China and in India were both have very big populations, and also the big populations of hypertension in stage 3. Also, there are also characteristics in our risk factors for the development of hypertension, such as high sodium diet and low potassium diet, and also aging is also a big problem. Then during the past few decades, we have the increased prevalence of obesity and the lower weight, which has account for the incidence of the high prevalence of hypertension in the middle-aged. And also we changed or modified our diagnostic standards of left ventricular hypertrophy and pot urine-based formula developed by our colleagues from the People's Hospital in Beijing University. And also we have noticed that stroke is the most important burden, the complications of hypertension in our country, which is relatively different from other parts of the world. And also we still have the increase of coronary heart disease, increased the incidence of atrial fibrillation, heart failure, and renal dysfunction. Also, I have to recognize that we have made a great achievement during the past few decades, and because we have more and more references and work have been cited from Chinese colleagues in these guidelines. And also this is the first time in the Chinese hypertension guideline that traditional Chinese medicine was recommended to use in certain conditions. We have updated the many parts of many chapters of this document listed as below, and also have more than 60% of the published data was in the last 5 years. We have actually 15 parts of the 15 chapters in this document, mainly consists of epidemiology, diagnosis, and risk stratification, treatment, and comorbidities, and also consists of recommendation in the resistant hypertension secondary. Also, a large part of the document was a perspective, the future research and the management of hypertension. For the epidemiological situation, that you can still find that there are still increase in the prevalence of hypertension during the past few decades, because the first hypertension survey was carried out maybe 60 years ago, 50 or 70 years ago, and it's a very low in prevalence because one of the reasons is the different diagnostic criteria in that time. But nowadays, clinical practice, we use the 140/890 mmHg as the differential, as the threshold for diagnosis of hypertension. So in the last survey was carried out in 2018 with the more than 27% of adult population have the hypertension in our country, and also which is a very profound increase in the prevalence of hypertension in the young subjects, which mainly account for the rapidly increase of the hypertension in the past few years. But still, the big problem is that though we have made contributions or made great progress in increasing the awareness rate, the treatment rate, but still the control rate nevertheless increased, but still quite lower than our neighboring countries such as Korea and Japan, and even lower than other parts of the world. It was around 30 to 40% of the population hypertension have been controlled in other parts of the world. And also we have our own characteristic of the high risk factors of development of hypertension in our population. I think most important thing is the high sodium diet, and also overweight, obesity, aging is also still a big problem. Excess of alcohol intake, and the emerging risk factors for development of hypertension is that the psychological factors and the air pollution and cancer treatment, because we have novel agents for treatment of cancer which have kind of increased the incidence of hypertension and cardiovascular diseases. Is a new situation they have to face up to. And also that some other important issues. And we also have noticed that still, although that the office blood pressure measurement is correlated closely with the development of stroke, coronary heart disease, and other cardiovascular events, as well as renal dysfunction. But still, we also have noticed that during the past few decades study that the out-of-office blood pressure measurement have been done a lot of work in this field, and also found a closer relationship between the out-of-office blood pressure measurement and the development of hypertension. And also the characteristics that although we have limited data indicating lower diastolic blood pressure which cause the lower incidence of cardiovascular events, but from the epidemiological studies such as longitudinal studies in our country, we have also find that IDH, isolated diastolic blood pressure, is closely related to the cardiovascular development, whether in the younger subjects or in the middle-aged patients in the under 55 years. This is the current situation in the out-of-office blood pressure measurement and cardiovascular risk. Also, in the central arterial blood pressure have been investigated to show that strongly associated with cardiovascular risk, such as than the brachial arterial blood pressure, especially in the younger population. And also, we also make some recommendations such as blood pressure variability in the management of hypertension should be taken into account. For the blood pressure measurement, in the last version of guideline, we only have 1.1 pages of introduction on the blood pressure measurement. But in this in the new document, we have add a new chapter for the blood pressure measurement. So still we recognize that office blood pressure measurement is a commonly used method for the diagnosis, classification, and monitoring the effects of treatments in the daily management of hypertension. Also, nevertheless, we encouraged our doctors to use out-of-office blood pressure measurement, ABPM or OHA home blood pressure measurement, to diagnose hypertension, not only for the identify the white coat hypertension and the mask hypertension, but also can be used for the daily management of hypertension, such as monitoring the antihypertensive effects and the diagnosis on the resistant hypertension, because from the reimbursement strategy or policy that ABPM can be reimbursed in many parts of our country, in our system, so more and more patients can use the ambulatory blood pressure monitoring in our country, even in the community hospitals. So we have made comparison between office and the out-of-office blood pressure methods, and we also have this the kind of devices more frequently used in the clinics for the automatic office blood pressure measurement, but still it is a lack of evidence now. So we have encouraged to make some to do some research work in this field, because other kinds of blood pressure measurement also still have a use for the diagnosis hypertension, which is a routine office blood pressure measurement, home blood pressure measurement, and automatic ambulatory blood pressure measurement. This have been talked about. Nothing I not have to talk in detail, but we have consensus in the encouraged our doctors to use it in daily clinical practice, whatever in the European guidelines or in Asian Hope Asia guidelines, and also I know that Nothing is also very collaborate with us in the development of these guidelines. And for the diagnosis and evaluation, we changed a little bit in our our policies, just because we have to consider that the hypertension itself is cardiovascular syndrome. Not only the blood pressure level can cause the development of the future outcome, but also the other risk factors and the underlying causes of hypertension, which may be some other kind of diseases per se, can cause the development of future cardiovascular events. So the diagnostic evaluation includes the following three aspects: establishing diagnosing of hypertension and determining the grade of blood pressure level, identifying the causes of hypertension, and diagnosing primary and secondary hypertension. In the third part of it makes a strict risk stratification based on the cardiovascular risk factors, target wound damage, and in the comorbidities. This is the flowchart of the diagnosis of and evaluations of hypertension based on the history, medical history, physical examination, laboratory tests, and the assessment of target wound damage. It's not very complicated, but based on the routine availability of the resources of the patients is not in a very high risk profile. This is basic items can be tested, such as blood biochemistry or ECG and blood routine count test. But if for selected items to be tested, is mainly for those patients with complicated comorbidities. For the optional items to be recommended only for the diagnosis of the secondary hypertension. So this is the diagnosis, blood pressure classification, and the hypertension grade based on office blood pressure measurement. So we still remain the diagnosis threshold 140 or 190 mmHg, and we have a high normal range of diagnosis hypertension. Diagnosis subjects with 120 to 138, 139, over 80 to 89, which was previously diagnosed as pre-hypertension in the GNC7, but the American hypertension guideline abandoned this definition, these categories. They changed that. But in Europe and in China, we kept the same category in the high normal blood pressure. We also have the similar recommendation of the isolated systolic hypertension and isolated diastolic hypertension. And then because we recommend the use of out-of-office blood pressure measurement in the diagnosis of hypertension, so we have the equivalent data or diagnosis criteria for the diagnosis of hypertension based on home blood pressure and ambulatory blood pressure measurement. 135 over 85 is the threshold for home blood pressure measurement, and 130 over 90 over 80 is the for 24-hour average blood pressure is the ABPM. This is the diagnosis of flow chart. It's not very complicated, but nevertheless, we encourage our physicians to use out-of-office blood pressure measurement in combination with the office blood pressure measurement, because it's more and more available in our country, because they also have a high prevalence of muscular hypertension in high normal range, maybe around 20% of the patients, and another 20% of the subjects may have white coat hypertension in the stage 1 or stage 2 hypertension. So the out-of-office blood pressure measurement is what needed. This is the risk stratification based on blood pressure, risk factor, and the target organ damage, and the clinical comorbidities, which is not seems to be complicated, but it's very practical to use in daily clinical practice, because if the patient with grade 3 hypertension, the risk profile is high or to very high profile, and also in patients with comorbidities, whatever the patients in the high normal range or in the hypertension range, the risk profile is quite high. Also a little bit of change in the interaction of the neuro risk factors, such as hyperuricemia and increase the heart rate. And also we have to change the diagnosis of the ventricular hypertrophy based on the longitudinal study from Shandong province, and also verified and have been tested by Professor Fong, our colleagues, chairperson here. And also they changed a little bit on the diagnosis criteria, so PWV, because also this kind of diagnosis is quite available in China. We also have the clinical complications here. And for the treatment, we have the treatment strategies with current evidence to support the use of antihypertensive agents in the relatively middle to high range profile, cardiovascular profile. So the treatment of hypertension should be based on the few strategies. We encourage the blood pressure per se, and the treatment on the associated risk factors. This is for the staging of the patient. First one is the grading of the patient based on the blood pressure level. And the most important one is correction on the treatment on the underlying causes of hypertension, which means the typing. So the grading, staging, the typing are the mainly fundamental theoretical strategy in our guidelines. So in this concept of grading, staging, and typing hypertension treatment are reflected in different sections of the guidelines. This is firstly introduced by the president of the Chinese Hypertension League, Professor Jiguang Wang, in his document 20 years ago, based on the treatment hypertension. The number is the stage or grade, then based on the comorbidities or risk factors is the severity of evaluation of the patient. It's the staging. It's the face of the subject. The most important one is the typing of the patient, not only for the second differential diagnosis of primary and the secondary hypertension, but also even in the range of the primary hypertension. There are several important risk factors that can maybe account for the development of kind of blood pressure level increase, which is obesity, high salt intake, salt sensitivity, and psychological issues. So we have some method to correct these risk factors in nowadays clinical practice. So the current evidence support that the beneficial effect from antihypertensive patients mainly come from the patient with moderate to higher risk profile, even in the high normal range blood subjects. But the most important thing is we have to consider the way the benefits against the risk, potential risk in the treatment of hypertension in other clinical practice, especially in use of antihypertensive drugs, or even in the lifestyle modifications such as the movement, the physical activity. So the timing of the treatment of the antihypertensive drug treatment, we based on the current evidence, we support that to use this in grade 2 patients. We should treat these patients immediately. But in the stage 1 hypertension with 140 over 90 over to 160 over 100 mmHg, if the patient with moderate to higher risk profile, this patient should be treated with antihypertensive agent immediately. Otherwise, we can have 1 month to 3 months lifestyle modifications. But for patients with high normal blood pressure, with very high or higher risk profile, the antihypertensive treatment should be drug treatment should be initiated immediately. But for lower and moderate treatment, we encourage the patient subject to receiving lifestyle modification. This is the flow chart of the treatment. It's very practical to use in clinical practice. So the blood pressure target, we have 2 stages. For the initial stage is that for treatment to lower blood pressure as low as 140 over 90 mmHg or lower. If the patient tolerated, 130 over 90 mmHg should be achieved in most of the patients with hypertension. But for the elderly, we should be weigh the risk of the benefits over the risk. Nevertheless, the current guideline encourage that we should treat those patients more aggressively for tolerated patients lower as 130 or 80 mmHg if the patient tolerated. This is based on the different phenotypes of the subject or different comorbidities of the subject. So because the time limit, I have to stop here. This is the main brief introduction of our current guideline. Thank you very much.